Thanks a lot for the opportunity to be here and talk to you today. My name is Matt DeCamp. I'm in the Center for Bioethics and Humanities and also the Division of General Internal Medicine at the University of Colorado. I'm a practicing internist. My PhD is actually in philosophy and ethics, and I also do some qualitative research. And I've been involved with ethics and short-term global health really over the past decade and a half, I'd say. And so it's a real treat to be able to spend some time with you today and talk to you about ethics and short-term global health. A little bit of an eye, actually, to how this is a microcosm, could be a microcosm for the way we think about global health more generally. No active relevant conflicts to disclose. These are some places where my research has been funded. What I want to do today over the next half an hour or so, I hope, is give you some brief background on what short-term global health is. I'll tell you about how we got to where we are. I'll talk about where I think we are now, and maybe also where we should be going. I want to make a note that we frequently talk about in short-term global health trainees, but this isn't meant to only be about undergraduate or graduate medical trainees. I think it's important that in global health, even seasoned practitioners who may not be steeped in global health itself can still be considered trainees. So forgive a little bit the use of some of my terminology. So what is this phenomenon of short-term global health experiences? Classically, we think of these activities as weeks to months long trips from a high-income country to a low or middle-income country to provide care. But if we look at these terms, short-term, global, and health, we can see that reality is quite a bit more complicated. There's no real standard definition of what counts as short-term. In some of the surveys we've done, we interestingly find that people say, well, it's whatever shorter than what I've done. So if I've been abroad for 4 weeks, short-term is 2. If I've been abroad for a year, short-term, 6 months. So a lot of ambiguity about what short-term is. There's also ambiguity in global. Are we talking about areas where we have to travel abroad? Could it be underserved areas locally? The mantra local is global and so on complicate the way we think about the word global. And of course, what counts as health? We talk only about health care. What about public health? What about education? And so on. So some of these terms add a lot of complexity to even how we start to think about describing this phenomenon. Now, short-term global health experiences sometimes find themselves in the news, not always for good reasons. A few headlines here. Trouble with medical volunteerism, or my personal favorite, if you look closely at the lower right picture here, you can see an article describing how a 6-day visit to a rural African village can completely change a woman's Facebook profile. So clear critiques about what this activity called short-term global health is. We see in the literature a real meteoric rise of interest in short-term global health. This just shows you publications, citations by year under the somewhat outdated, I would say, medical subject heading of medical missions. You can see they're going off the charts as we approach today. And also, I'm more familiar with medical student activities in global health, and we can see that many medical students continue to participate in global health activities, 30% or so in 2015, slight reduction into 2019, but still about 1 in 4 medical students going abroad on a global health experience. Now, the reasons for why we're seeing this slight decline, I think, are unclear. COVID will probably change some of that as well. Interesting to see what happens to participation over time. So what are the numbers? I think the precise estimates are really challenging here because of the disseminated, unregulated nature of global health. Most people believe that short-term activities are completed by hundreds of thousands, if not millions, of volunteers annually. They likely involve hundreds of millions or several $billion US each year. They frequently include research and service, both clinical and non-clinical alike. And they do range in duration from a few weeks to a few months, as we talked about before, related to what counts as short-term. Now, importantly, this is a real global phenomenon. Just as an example, 40% of UK medical students actually go abroad to complete global health electives as well. So all of these facts, all these figures, I think, really underscore the importance of thinking through, well, what are the ethics of doing short-term clinical experiences abroad? So let me talk a little bit about the past and how I think we got to where we are today when it comes to short-term global health. Now, we may see this as somewhat new. You've seen that meteoric rise, but we can trace the history of short-term global health back to medical missions of the 19th century. And I think if we do, three themes emerge. First, these are often values-driven. That is, global health work is often motivated by appeals to ethical values, concepts of need, duty, social justice, and so on. Second, this notion of trainee involvement has been common throughout the history of medical missions into short-term global health. From the 19th century to HIV/AIDS epidemic of the 20th, students and trainees have always been participating in global health experiences. And lastly, complex and conflicting dynamics. Global health service with undercurrents of racism and colonialism dating back to those days of medical missions, where some of the most well-known figures in global health, Albert Schweitzer, for example, both had interesting racial views as well as issues around structural power and power imbalances, a complex set of dynamics that cast a shadow on what we do and how we think about global health today. And I want to just highlight this because we're going to come back to this concept towards the end of the presentation. Now, I would say that over the past decade and a half that I've been interested in this area, that we've actually made moral progress. And I describe this moral progress as follows. We start out by thinking about global health activities, these short-term experiences, as altruistic. Now, the heart of altruism is giving something away at cost to oneself, right? It has to come at cost to me for it to be a truly altruistic gesture. But then we say, wait a minute, individuals actually benefit from these experiences educationally, experientially, maybe attitudinally. And so perhaps it's better to think of it as an issue of charity, that is giving something away. You're not obliged to do it, but it's something that's really nice to do. And then we stop again and say, wait a minute, individuals can actually cause harm in these experiences. Remember those news headlines, 105 Ugandan kids, deaths contributed to by a short-term volunteer. If individuals are causing harm, maybe we should really think about this as an issue of justice, which is giving to others what they are due. So I think we've shifted from altruism to thinking about short-term as just experiences as a matter of justice. And I leave open again a question mark to come back at the end and ask us what the next step in thinking about global health experiences could or should be. Now, you may think it's a little bit of philosophical wrangling to talk about distinctions of charity versus justice, but in fact, this is really important from the standpoint of ethics because we think about obligations very differently when they're from charity versus justice. So charity obligations are often imperfect, we say. They're not stringent. You have a lot of discretion in terms of what you do, what you give, with whom you interact, and you see the receiver as really being an object of charity. This is the charity obligation bucket. Obligations of justice are quite different. We describe them as being perfect, as something that you are fully obliged to do. There's less discretion over how much to give or what to give, and it sees people somewhat differently. It sees people as subjects of justice, where subjects here is not like human subjects research. It's actually more related to the concept of human rights, that people are subjects of rights, of right bearers in their own sense. So this shift from charity to justice is really important in how we think about those with whom we interact globally. One simple way of viewing this distinction and what I've seen as progress over the past 20 years is really a rejection of the something is better than nothing approach. So if you remember just one thing about this slide, I think it's this, the rejection of something being better than nothing. I'll say a little bit more about how we got to where we are. In the 1990s and 2000s, I think there was this recognition of the importance of ethics, especially unintended harms. Mainstream journals publishing articles, pointing out cases and anecdotes where harm really did occur because of short-term global health experiences. What issues were flagged in these articles? Well, differences in cultural norms, such as around gender, issues of consent and respect, unintentional harms like the side effects of medications, doing things abroad that you would never do at home, that is exceeding scope of training, unintentional burdens on the host that take away from individuals or the host's own obligations of work and life and so on, the savior complex, sustainability, the fungibility of resources. Should we be buying plane tickets to go abroad, or should we be donating those resources to an NGO, a local NGO that could better serve the population locally? Different standards of care and so on. So case reports, a lot of them noting and pointing out these problematic ethics issues and asking for people to address them in short-term programs. You know, one in-depth example of this, just to make it concrete, is this notion of standards of care. Here's a text message I got a year or two ago from a friend. It's anonymized, right? It's a friend who says, "Did I tell you I'm in Ethiopia?" And I say, no. Anyway, the med group here wondering if we should use expired meds 1 month that we brought to Ethiopia. I'm sure you ethics guys have some view on that. And I say, so you're asking if it's okay to use expired medications. Well, this is an example, right? Imagine you're abroad. You see a patient with a bacterial infection. You only have one antibiotic with you, but it's expired. What are the ethics of using expired medications? Is it only about whether it works technically as a matter of beneficence? Is it only about whether the community is informed? As long as you tell them it's expired, well, then it's okay. Or is it really none of these things? Now this, although it occurs in a short-term program, is really an example of the pervasive problem of defining standards in global health. Is there one standard of care that's universal? We think about the historical legacy of HIV trials, the rotavirus vaccine, the treatment versus prevention so-called debate of HIV in Africa and so on, or more recent debate about the use of less expensive or less effective medications globally. So a recent interchange in the Lancet about this exact topic. Is it okay to use less expensive and less effective medications globally? Where a debate breaks out between bioethicists on one side who say this is a matter of the greatest good for the greatest number. You can do more good using the less expensive, less effective medicines, as long as the community is informed about it. Whereas others, like Doctors Without Borders, saying, no, this is not bioethics. This is an ethics of resignation. It's being too quick to accept the status quo rather than demand the change that would be needed to bring standards together universally. A really interesting interchange that I encourage you to read in the letters in response to a paper in the Lancet. Now, for many, the concern is more about, I should say, how we come to this kind of decision and what our actions mean, not just what the concrete action itself is. And then back to my friend and that text message exchange, as it turns out, there's been guidance on this topic about donated medications for many years. The World Health Organization has long had guidance that in fact basically says you shouldn't use or bring expired medications except in the rarest of circumstances. So for many of the issues we talk about, just a reminder that in some cases there is guidance out there. It's important to be aware of it. And in this case, it very clearly, I think, makes a statement against this notion of a double standard. Fast forward a little bit, we had those cases, those anecdotes of unintentional harms. In the 2010s, the academic community especially responded to calls for ethics guidance on particular topics and created ethics guidance. Here are a couple notable examples. The weight guidelines, guidelines from Canada, guidelines from the American College of Physicians, to which I contributed, about trying to offer solutions or at least guidance for some of these vexing problems in global health. In fact, some would say we eventually got to the point we had too much of a good thing. In a 27 published ethics guidelines, Judy Lasker and colleagues basically came up with 5 unifying principles or guidelines, summarizing in a synthetic way all of those guidelines that were promulgated in the early 2010s. Appropriate recruitment, preparation, and supervision. A host partner that defined the program, including the needs to be addressed. Sustainability, respect for governance, and regular evaluation, all 5 core principles for how we think about the ethics of short-term experiences. And I just want to highlight something. I think if you look closely at these principles, the idea that a host partner defines the program, the importance of sustainability, I think you can see principles that look a lot more like obligations of justice, as I previously described them, than they are obligations of charity. So I think this reflects that progress, that shift from altruism to charity to justice to get us where we are today. So where are we? Well, I think there's now really importantly widespread recognition of the need to prepare for ethics in short-term experiences. This is the World Medical Association making a statement on ethical considerations in global medical electives. That American College of Physicians statement, I think also an important reflection of and recognition of the need to address ethics issues when it comes to short-term global health. A really important, I think, landmark moment for those of us interested in this area. And you might say, well, we're talking about preparation and ethics preparation. What do we know about ethics training? Well, there have been a few evaluations of different programs that have been used to prepare individuals for clinical experiences abroad, specifically around ethics. I'm not talking about just logistics or other sorts of issues. These are ethics-specific programs, Wisconsin, UCSF, and Yale. I think if you look at the slide, you can see a couple things. On the left, you notice that it's pretty limited numbers of people that have been evaluated. And on the right, notice something about the outcomes here. Training that's perceived as useful. Individuals that believe the simulations were useful or made them more aware and improved a sense of preparedness. So what you're seeing here are largely self-reported outcomes, not what many of us in evaluation context would say are real hard outcomes, right? Better behavior and so on. We'll talk more about that. And here, in fact, is a cautionary tale from a pre-post evaluation we did of our introductory ethics curriculum, ethicsandglobalhealth.org. Pre to post, notice the top line. Confidence of our trainees skyrockets. 49% to 88% agree or strongly agree with being confident in how they will manage ethics issues before and after our 10-case series. But look at knowledge. We created a 5-question ethics test to see how much knowledge had improved, and it didn't. So confidence skyrockets, but knowledge does not. This caused us to ask really hard questions. Are we doing the right thing? What should be our goal? Should we actually be seeing a reduction in confidence if we expose people to some of those challenges I talked about? How do you measure ethics knowledge? What are the outcomes that we care about? And so on. So a cautionary tale, I think, about how we should evaluate ethics curricula and ethics training. What are the gaps as I see them? Well, I think, as I said, limited numbers of trainees have informed the existing literature, particularly in light of those many thousands, I said at the beginning, who go abroad. Most of these evaluations are self-reported or perceived outcomes. So if we look at the pyramid of evidence, you can see we're on a pretty low level at the moment. As far as levels of evidence regarding ethics challenge and their management, probably case series. So although we've made progress to this point in the story, I think there are significant questions that remain about how we evaluate and make sure that when we prepare people for ethics stuff abroad, we're actually doing a good job. So where are we going? I'm going to talk about a few challenges for the future. I cut one out for the sake of time. I'm only going to talk about 2 of these, so we have a little more time for Q&A. And the first one follows directly from what I was just describing. What counts as success? At present, I think there's little consensus on what success means for ethics evaluation. Is it ethics knowledge, that knowledge test I described that we did? Should we see improvements in attitudes, behaviors? Are we teaching people substantive right versus wrong? Or are we teaching them decision processes? Or in the end, are we really more concerned about real outcomes, that is, improving global health equity? Sadly, at present, there's little evidence beyond some of these case reports and individual programs that short-term global health equals improved global health. And this is a systematic review that describes that. Now, when we think about what counts as success, we're actually reminded of a debate from about 10 years ago in medical ethics and professionalism generally. And that's about whether we should focus on ethics in terms of behaviors, etiquette-based medicine, behavioral and systems views of professionalism, or ethics as character, education, or apprenticeship, and so on. And this debate turns out to be relevant for how we think of global health ethics. Now, the classical bioethics approach, I would say, is somewhat behavioral. We have these time-honored principles that many of us learn in clinical ethics: respect for persons, beneficence, and justice. And what we often think of evaluating related to these principles are behaviors: informed consent, risks and benefits, equitable distribution of benefits and burdens, protection of the vulnerable, and so on. And I think you see this behavioral style approach reflected in some of the ethics guidelines that are out there. The weight guidelines, ACP guidelines, I think, are behavioral. This is somewhat different than that character-based approach, which we can see in these guidelines, Global Health Ethics for Students, where the principles and concepts used are different: introspection, humility, and solidarity. Notice how these questions are different. Why am I engaging in this global health research or service program versus what am I going to do? The why versus the what, a really important distinction. What are my own limitations, and am I exceeding them? How do my actions demonstrate unity independent of their tangible impact? These are fundamentally different questions to be asking about global health. Now, recently, a few of us have published on the idea that, in fact, these two approaches may be better off together, that we need these concepts of introspection, humility, solidarity, and justice in order to understand how we would apply these basics bioethics principles in unfamiliar places. So in other words, these yellow concepts are actually foundational to how we interpret those core concepts of biomedical ethics. Let me show you this with an example. I mentioned this issue of performing outside scope of training. I think this illustrates nicely how if someone is asked to perform outside their scope, how important humility, introspection, and so on are to this ethics analysis, particularly when, if you look closely at the ethics guidelines that are out there, they say something like this: a classic hedge. It is usually best not to exceed your scope of training. So when the principles of biomedical ethics say, well, what just are the risks and benefits? Was the individual aware or informed? Am I applying my decision the same in all circumstances? When the principles say that, these other character-based concepts ask, am I humble in assessing my own skills, or do I have a hero complex? Are power imbalances minimized as a matter of solidarity, an us versus them mentality? Or am I the right person to be making this decision in the first place from the standpoint of introspection? So the synergy that's possible between those classic principles and those character-based concepts. Challenge number 2 about this issue of ethics and defining outcomes and what matters is really the question, who decides? Who decides between competing conceptions of ethics or of what matters most? Literature, I think, is too infrequently asked what these local priorities are. But if you look at some of the recent articles that are out there, there are some interesting findings. And although the evidence is somewhat sparse, I think there is a signal in the literature that really does ask this question of how or why, and says it's just as important as the question what. So let me give you one example. Look at the table in the lower right. This is looking at the percentage of local hosts who consider particular global health competencies important. And look what number 1 is: humility. Look at the bottom of the table, being able to tangibly conduct or assist in research. So you can see local communities, local hosts, being more interested in some respects about concepts of humility than the exact what, and the exact tangibles of what's being done in a particular program. Wouldn't overinterpret this finding. The what still matters a lot, but what an interesting idea to explore that some of these competencies are seen as more important locally. You might ask, well, what do I think about evaluating effectiveness and how would we evaluate programs? Just a few ideas here. I think whatever approach to measurement we choose when we evaluate, it has to be developmental. There's no one size fits all. Remember, if we only choose successful, ideal, long-term partnerships or places where our cultural norms agree, this always leaves people out. And that itself is a matter of justice. We have to be collaborative, as I mentioned, decided with and by local communities. We need to be progressive, listening to human rights concepts about timelines and benchmarks. We have to have specific timelines and benchmarks to achieve over time. And of course, we have to be non-exploitative, that is, not benefiting at others' expense. And I want to say a brief comment about this that may be a bit provocative. If you look in the literature, some will describe how time abroad can improve knowledge, skills, and attitudes of trainees. It's a really important outcome, even leading them to careers in serving underserved and marginalized populations at home. And we might all agree that these similar ethics concepts apply in these different settings, but I think this approach, this attitude raises far more questions than it does justify short-term global health. We might ask, why should we go abroad to learn these lessons? Can or should we learn them in our own communities? And is this really a subtle or even bizarre form of exploitation of uniquely global communities that we benefit abroad and then we come home and bring benefits here? So a provocative notion, but something that could be worthy of more discussion. As I get towards the end of the presentation, remember I started with this question mark left. What's the next stage of progress when it comes to short-term global health? And I want to ask, is this next stage taking seriously the notion of decolonization or decolonizing global health? Recently, if you've paid attention, there's been a building movement under this rubric of decolonizing global health. And I think we should ask, what would it mean for short-term global health? Look at this Twitter account. If you look closely, it says, we're bored of the Gates Foundation telling us what to do. A student account, as most students can say, really refreshing notion here, emphasizing decolonizing global health. Remember, the hallmarks of decolonization are really about self-determination and eliminating structures, all structures, financial and otherwise, that contribute to neocolonialism, that is, colonialism that occurs even when technically entities are politically independent. I think we should ask, what would decolonizing global health mean for these ethics concepts we've seen in short-term global health, mutual benefit, sustainability, or dare we say, even those Western bioethics principles that I've used in this very talk. Now remember, this does have rhetorical appeal. It's easy to join the Twitter excitement over the concept of decolonizing, but we have to be clear about what it means in the rich literature around decolonization and neocolonialism. Remember, decolonizing is not merely political independence. Neocolonialism tells us that financial and other institutional structures and policies matters just as much as politics. It's not about disengagement, right? It's not that we leave a place where we created a mess. We have to still allow for the right kinds of partnerships in global health. It would be inappropriate to leave a mess that we created. And it's also not about what some in the link at the lower right have called fake decolonizing, that is, restoring one's own image without actually addressing the structural imbalances that exist in global health. Indeed, I think taking decolonizing seriously might mean rethinking what our traditional principles mean or rethinking them altogether. So here I have a slide that shows those 5 consensus principles. If we look at them through the lens of decolonizing, do we have to refine those principles, right? When we talk about appropriate preparation, does that mean we have to educate and analyze cases in some of these curricula with attention to colonialism and today's colonizing influences? When we talk about regular evaluation of impact, does it mean that the evaluation should really be led and driven by the local community, not people like me from the outside evaluating or determining what matters most? So I think a real concern about bioethics and bioethics principles is, what would it mean if we took decolonizing seriously and applied them to those core principles? So I'm going to stop here with just a couple conclusions and reflections, and maybe we'll have time for a little Q&A. Remember, I think that while a lot of work remains, it's reasonable to suggest that we have made progress in the policy and practice of short-term global health, progress that sees this through the ethics lens of justice. There is a real need to evaluate the effectiveness of ethics training with a critical eye toward whether we have the ethics right in the first place. That's where decolonizing comes in. Remember, how we view short-term global health really can be seen as a window into how we view global health more generally. The way we approach this topic, I think, reflects issues around colonialism, racism, structural imbalances, and so on. So how we approach this issue should really reflect how we approach global health more generally. And I would say, perhaps controversially, that arguably the end goal is to no longer need short-term global health activities at all, at least not as they're now conceived. So I really appreciate your time and attention. I think we do have a little bit of time left for Q&A, and I'm just going to stop sharing my screen. Thanks a lot.
Thank you so much, Matt. That was terrific. And you definitely echo what a lot of us, the leaders here, agree with and support and are trying to reckon with, particularly this idea. Oh, here we've got a nice question from Colleen that's specific, but we're all trying to figure it out together, right? I can get back to my question, but Colleen, do you want to ask your question directly and maybe even let him know what our sims have yielded?
Yeah, hi. This was super helpful. I love the way you kind of frame stuff for us and given us a lot of like, even just like words to use to describe things we've been working through. I thought it was so interesting how you brought up like the ethics training and how people's confidence improved, but then their knowledge stayed the same. Which I think is the challenge when you're like evaluating teaching and curriculums, and it's hard to evaluate, those more distal outcomes. Have you seen anything that works? Like, how would you, like, what do you think is a better way to kind of evaluate ethics teaching? I'm interested to know.
Yeah, it's a great question because, as you mentioned, this is a question that dogs medical education and certainly dogs medical ethics education too, right? It's not unique, although it's probably particularly, I think, challenging here because of the global context. I think I've long wanted to do an evaluation that really looks at attitudinal and actual outcomes with the host or local community in mind, right? Because ideally, what do we want out of ethics training? I think we want people to be better prepared for more successful partnerships that over the long term build local capacity for global health. And the more we can get towards those kinds of outcomes that ideally are defined by and driven by the local communities, the better. Because I think the existing evaluations, and here I'm only talking about the ethics program evaluations, are in that early stage that we'd all expect, right? Self-reported outcomes, knowledge, confidence, attitudinal domains. Those are important, but that's the first step. I really want us to get to where thinking about how does this affect, on the ground behaviors, partnerships, and long-term success. That's separate, I should say. I won't say much about it. It's separate from the question of how we evaluate overall programs, right? That's a different evaluation question than the ethics education, although probably some of the similar concepts apply.
Oh, I'll turn it over to Bill. Professor.
Matt, terrific presentation. Thank you. Very, very thoughtful. So the issues that you raise are central to global health education. I guess one of the things that I'm wondering about is the task in terms of training is a very, very large one. And in medical school, there is only so much time. I'm wondering if you can perhaps speak from your own experience about the kind of background and training at the undergraduate level that may help to facilitate and advance the kinds of changes that we're looking for. I ask this as the director of our undergraduate program in global health studies here.
Well, it's a great question. It's a hard question. Time is limited. If you looked at the details of those ethics education curricula that I showed, they are pretty short and self-contained, some simulation trainings that can be done in a reasonably short period of time. But I think if I put on this decolonizing hat or use this decolonizing lens, I think there is a concern that at the undergraduate level where students are often taught these Western bioethics principles and approach. I'm not 100% sure that that prepares them best for a global health ethics approach. And if you've already, I don't want to say stacked the deck, but it's sort of that way, right? You stacked the deck in favor of Western bioethics principles. It's really hard to get out of that mindset when it comes to the global health ethics. And I'm, so I don't know, maybe is there some way to be more global in the way we teach core ethics that prepares people better for these kinds of experiences? And, there's probably some synergy to be had with global health ethics, even for local, more domestic oriented issues. So I can't, I don't know exactly how your program is structured or what is taught, but that's a thought I had. And I think that decolonizing pushes us to do it that way.
Well, I mean, our program takes as central to its mission a critical approach to development broadly and, the global issues in general. So it is imbued with that sort of evaluative decolonizing perspective as sort of central to what we're trying to attain.
It's interesting too, just to add that there have always been echoes within biomedical ethics, right? Or undercurrents, I should say, of people critiquing the principle approach, right? People who are more interested in teaching about virtues and character, even though arguably the principles have become the dominant way of thinking. I mean, if you look at the ACP statement I helped co-author, it's framed around those principles, right? And I try to bend them as much as I can to be a little more globally oriented and more justice focused. But, there is this hard question of if that's what we're anchored to, what are we missing? And maybe the more we can expand that early on, the more prepared people will be for some of these challenges, again, either locally or globally.
Yeah, thank you, Matt. I agree. I think that another question I had that's sort of related to that is acknowledging, because something is better than nothing. The like 3 things: do no harm, something is better than nothing. My third one, and this is my personal experience, is just I get more than I give, or I learn more. And it's the same idea that you brought up. I really toy with this, like, is it appropriate in the social contract space to go learn that, in other places? But knowing that, and knowing that there is growth and development in that work, and maybe acknowledging that everyone is a trainee in this space. That opening line that you said, because I always feel a little bit funny as saying, I'm faculty and I get more than I give, or I always learn more. I always do, right?
Yeah.
Can it help
and
that justice spot in some way, like a justice plus, a justice in my benefit or something? I don't know.
Well, the when I threw up the concept of exploitation, right, like that gets people's attention, right? When someone says, well, I get more than I give, and I come back and say, well, that's a good example of exploitation. But that gets their attention. There's a more sophisticated discussion to be had, right? And we can talk about the details of what makes something exploitative or not, but it's certainly, polemical to say that, and then to have that more detailed conversation. It's not to say that benefits to the individual trainees don't matter, right? It's how to put those in the right context and how to structure a program in such a way that even when those benefits are occurring, it's happening in a way that's really not exploitative. And that's possible to do, but it requires thinking about it.
And a lot of work. Do we have any other questions from our trainees?
Yeah, happy. I know I rushed through a lot of stuff. Maybe some people disagree.
Yeah, please feel free to put in the chat. I mean, the other thing that comes up too, Matt, is like that idea of decolonizing and our role decolonizing. Perhaps our role colonizing is so structural, like maybe the IMF needs to just give everybody all the money back from structural reforms, right? Like that is the level of reparation that may be needed. And I know that's like maybe totally pie in the sky, but perhaps that's like the real honest truth, because it comes down to resources, right? And finances and the way money flows and things like that.
Well, yeah, it's a great point. On the one hand, when we talk about decolonizing, there can be a reaction to it that looks at the individual level, and individuals would say, well, gosh, what in the world could I do? Look, this is all driven by higher level policy structures and historical injustices that I had no part in. And now I just have to throw up my hands and say, well, I can't do anything about it anyway. But that's not really true. Like if you look at individual case examples, globally, in the role of individuals, being aware of colonizing influences and calling them out and asking for structures to change, even at the institutional level, right? That's probably where we have more of a sphere of influence, is at our local institutions. Then, maybe you have more influence at the IMF than I do.
I wish I did. I mean,
but we do have influence at the institutional level. Some good examples of that, I think, come about when we talk about collaborations and how authorship can work, how funding can work. There are ways that we individually can act that, reflect awareness of, and, in some ways opposition to those colonizing forces.
Thank you, Matt. I don't know if I see that Professor Bekele is on already. I don't know if I don't want to put you on the spot too much, but as our actual, leader in global health education, in a place where many of our trainees have come and gone, I wonder if you could make a comment about some of this.
Not so much, Ashley. Thank you very much for having me today. It was a very interesting conversation. The conversation about decolonizing global health and ethics. I really enjoyed. I wish I had joined earlier. I would have had a lot, few words to say. Thank you for the invitation.
Thank you. Okay. Terrific. Any other comments, questions?
I like the comment in the chat. It says maybe we need to decolonize our.
Yeah, absolutely. And actually, Matt, you probably know this. The early decolonizing literature, there's like a paragraph there that says, if you're in the global space and you're thinking about decolonizing, look to your local space first, and look to your First Nations people and see what you. It actually, there's like a paragraph in that seminal paper. I think Leah mentioned it to me a long time ago. That first decolonizing paper. They're like, if you're doing this globally, take a step and begin at home if you really want to make progress in the space.
It's a great reminder of that local is global, and the way all of these issues can be connected. And we do ourselves a disservice when we compartmentalize, global health away from the local. And it is really important to see those can be together and act together in a way that's synergistic.
Well, I can't thank you enough, Matt, for giving us this entire tour de force of global health and ethics and ways to think. And I've gotten a lot of text messages that you're going to be invited to a lot of curricular restructuring and design at Northwestern University if you're interested. So we look forward to your expertise and helping us work through this. Thanks, Kristen. Thank you so much.
Thank you. Thanks.